Hi, and welcome viewers of Nursing Academy 101. Today, we are going to take a quick overview of the top tips on the maternity-related disorders to aid the NCLEX and Prometric exams for nurses. But before we start, please don't forget to subscribe, like, and share the channel to encourage us to continue and provide you with all new. First disorder, acquired immunodeficiency syndrome (AIDS) during pregnancy. A woman client may first test positive for HIV antibodies during pregnancy or when the HIV status of the newborn is determined. Pregnancy can accelerate the progression from HIV infection to advanced AIDS due to the immunosuppressive effect. The characteristics, signs, and symptoms. It includes diarrhea, fatigue, presence of Kaposi's sarcoma, mild flu-like symptoms, occurrence of opportunistic infections such as toxoplasmosis, oral and vaginal candidiasis, herpes simplex, pneumocystis carinii, and candida esophagitis, anorexia, and weight loss. The diagnostic test results: CD4 T cells count less than 200 cells per millimeter cube, positive human immunodeficiency virus HIV antibodies titer, as shown by enzyme-linked immunosuppressant assay ELISA, positive Western blot test. The nursing diagnosis: 1. Fear, 2. Fatigue, 3. Ineffective protection, 4. Anxiety, 5. Ineffective coping. The treatment: same care provided to any other client with HIV, close monitoring of the fetus with serial ultrasounds to detect intrauterine growth restriction, weekly non-stress tests performed after 32 weeks of gestation. If the client is newly diagnosed, zidovudine, retrovirr, or didanosine Videx is typically initiated between 14 to 34 weeks of gestation. The interventions and rationales: evaluate for fever, chest tightness, and shortness of breath to identify possible recurrence acute pneumonia or pulmonary tuberculosis, which may indicate AIDS. Administer total parenteral nutrition (TPN) if necessary to improve and support nutritional status. Provide rest periods to prevent fatigue. Offer emotional support to the client and her family to alleviate fears. Evaluate the client's ability to care for her infant after delivery to determine the need for additional support service. The teaching topics: explain the disorders and treatment plans, educate on medication use and potential adverse effects, teach methods to prevent the spread of infection, discuss ways to reduce the risk of transmission to the fetus by avoiding unsafe sexual practices or discontinuing intravenous drug use. Provide counseling to assist the client in making decisions regarding the continuation or termination of the pregnancy. Second disorder, adolescence pregnancy. A pregnant teenager is vulnerable to potential complications, including hypertensive disorders of pregnancy, cephalopelvic disproportion, anemia, and nutritional deficiencies. Additionally, teenagers have a high risk of sexually transmitted disease, which can affect both the mother and the newborn. Infants born to teenagers are at an increased risk of prematurity and low birth weight. The characteristic signs and symptoms of this disorder: denial of pregnancy, which may hinder the adolescent from seeking early medical attention. The diagnostic test results: positive result on the pregnancy test. The nursing diagnosis: 1. Deficient knowledge regarding pregnancy and care options. 2. Imbalanced nutrition, less than body requirement. 3. Interrupted family process. 4. Fear. The treatment includes: provide a diet with sufficient calories to support the growing adolescent and her developing fetus. Schedule regular prenatal checkups. Administer antibiotics for STDs if necessary. Prescribe prenatal vitamins with iron. The interventions and rationales. Monitor the teenager's weight gain to identify nutritional deficiencies. Assess the teenager's understanding of her pregnancy. Determine the need for further education. Gather information about the teenager's family and available support to determine potential referrals. Offer nutritional support and encouragement to promote the well-being of the mother and fetus. Emphasize the importance of attending scheduled prenatal appointments to ensure the well-being of the mother and fetus. Discuss the teenager's options, including terminating the pregnancy, adoption, or raising the infant to facilitate informed decision-making. Create a safe space for the teenagers to express her feelings about her pregnancy and herself, promoting her mental and emotional well-being. The teaching topics include providing information about the teenager's condition, any identified complications, and the treatment plan. Encourage attendance at prenatal, birthing, and infant care classes. Emphasize the importance of prenatal care. Third disorder is diabetes mellitus in pregnancy. In gestational diabetes mellitus, the client's pancreas, which is strained due to the normal adaptation during pregnancy, can't meet the increased insulin demands. Gestational diabetes can occur either in clients with pre-existing diabetes or developed during pregnancy. It's associated with a higher risk of congenital anomalies, hydramnios, macrosomia, hypertensive disorders of pregnancy, spontaneous abortion, and fetal death. Furthermore, infants of clients with diabetes are at risk of sacral agenesis and incomplete formation of the vertebral column. Also, clients with gestational diabetes have an elevated risk of developing diabetes mellitus later in life. The characteristics, signs and symptoms: presence of glucosuria, presence of ketonuria, frequent urination polyuria, and the diagnostic test results: glucose level greater than 140 mg per deciliter in the 1-hour glucose tolerance test. The nursing diagnoses include imbalanced nutrition more than body requirements, risk for deficit fluid volume, ineffective cupping, fear, and anxiety. The treatment include regular monitoring of capillary blood sugar levels, incorporation of exercise into the daily routine, following a 1,800 to 2,200 calorie diet divided into 3 meals and 3 snacks, emphasizing low fat, low cholesterol, and high fiber option. Insulin or gluburate diabeta may be prescribed after the first trimester. Other oral antidiabetic agents are contraindicated due to adverse effects on the fetus. The interventions and rationales: encourage adherence to dietary regulation to maintain normal blood sugar level, promote moderate exercise to lower blood glucose level and reduce the need for insulin, prepare the client for antepartum fetal surveillance tests such as OCT, nipple stimulation stress test, amniotic fluid index, biophysical profile, and NST to monitor fetal well-being. Encourage the client to express her feelings to alleviate fears, provide emotional support to reduce anxiety. And the teaching topics: explanation of the disorder and the treatment plan, proper use of medications and awareness of possible adverse effects, performing capillary glucose monitoring, and conducting fetal kick count to assess fetal well-being during the third trimester. The fourth disorder is ectopic pregnancy. Ectopic pregnancy refers to the implantation of a fertilized ovum outside the uterine cavity. The most common location for ectopic pregnancy is the fallopian tube, but it can also occur in the cervix, ovary, or abdominal cavity. It is the second most common cause of vaginal bleeding in early pregnancy. The characteristic signs and symptoms: regular vaginal bleeding, which may be followed by bleeding after a period of amenorrhea, abdominal or pelvic pain, which can be sharp or dull, rupture of the fallopian tube, resulting in sudden and severe abdominal pain, syncope, and referred shoulder pain due to blood accumulation in the abdomen, smaller uterine size compared to expected gestational age. The diagnostic test result: abnormally low level of a human chorionic gonadotropin (HCG) titers compared to a normal pregnancy, lower serum progesterone levels than in a normal pregnancy. The nursing diagnoses include deficient fluid volume, risk for infection, acute pain, and fear. The treatment includes laparotomy is performed to ligate the bleeding vessels and remove or repair the damaged fallopian tube. Transfusion therapy may be required if bleeding is uncontrolled, involving packed RBCs, and according to drug therapy, if the fallopian tube has not ruptured, methotrexate, Trixal, followed by leucovorin, is administered to halt the growth of trophoblastic cells. Therapy continues until negative HCG levels are achieved. The interventions and rationales: monitor vital signs, intake and output to assess for significant blood loss and shock. Watch for severe abdominal pain, orthostatic hypotension, tachycardia, and dizziness, as these may indicate a ruptured ectopic pregnancy. Administer intravenous fluid to compensate for blood loss. Administer blood product, and closely monitor the clients for adverse reaction during transfusion. Administer urogam to RIS-negative client to prevent isoimmunization. Provide routine postoperative care to facilitate recovery. Offer emotional support to parents who are grieving over the loss of the pregnancy. The teaching topics: explanation of the disorder and the treatment plan, proper use of medications and awareness of possible adverse effects, importance of follow-up medical care. The first disorder is the heart disease during pregnancy. Heart disease occurs in approximately 1% of pregnant women. Pregnancy can either reveal a previously asymptomatic underlying heart condition or exacerbate a known heart condition. The highest risk for a client with heart disease is during the peak blood volume between 28 and 32 weeks of gestation. The successful delivery of a healthy baby depends on the type and severity of the heart disease. Decreased placental perfusion can lead to intrauterine growth retardation, fetal distress, and prematurity. Pregnancy clients with heart disease are categorized into classes 1 to 4. The characteristic signs and symptoms: rapid heart rate tachycardia, shortness of breath, dyspnea, fatigue, diastolic murmurs at the heart's apex, crackles heart at the base of the lungs. The diagnostic test results: cardiac abnormalities, impaired cardiac function, and cardiovascular decompensations may be revealed through echocardiography, electrocardiography, and chest X-ray. The nursing diagnosis: activity intolerance, excess fluid volume, decreased cardiac output, and ineffective breathing pattern. The treatments include low sodium, low fat diets with fluid restriction if necessary, rest periods to prevent fatigue, oxygen therapy, drug therapy, class 1 and 2, antibiotics such as ampicillin and gentamicin to prevent bacterial endocarditis, class 3 and 4, anticoagulant heparin, antiarrhythmic digoxin, procainamides, beta-adrenergic blockers, antibiotics, ampicillin, gentamicin to prevent bacterial endocarditis, diuretics, thiazide diuretics, and furosemide Lasix to manage heart failure if activity restrictions and reduced sodium intake are not sufficient. The interventions and rationales: monitor maternal and fetal vital signs to assess the well-being of both. Assess cardiovascular and respiratory status to identify signs of maternal cardiac decompensation, such as tachycardia, tachypnea, moist trickles, and exhaustion. Administer prescribed anticoagulants, antiarrhythmics, antibiotics, and diuretics to follow the therapeutic regimen. Encourage the client to monitor her intake to avoid excess weight gain. Advise the client to limit physical activity based on her abilities and symptoms to ensure adequate rest. Promote 8 to 10 hours of sleep each night for the client to ensure sufficient rest. Monitor the client's IV fluid intake and output to maintain proper fluid balance. Administer oxygen via nasal cannula or face mask during labor to maintain fetal oxygenation. Position the client on her left side with elevated head and shoulders during labor to prevent supine hypotension syndrome. Continue monitoring the client during the postpartum period for signs of cardiac decompensation, even if no distress was observed during pregnancy and labor. The teaching topics: explanation of the disorder and the treatment plan, proper use of medications and awareness of possible adverse effects, dietary modifications, prevention of infection, recognition of signs and symptoms of heart failure, importance of receiving adequate rest. The sixth disorder is hereditary mole. Hereditary mole, also known as gestational trophoblastic disease, is a placental developmental anomaly characterized by the transformation of chorionic villi into a mass of clear vesicles called hydatid vesicles. There are two types: complete mole, there is neither an embryo nor an amniotic sac, and the partial mole, there is an embryo, usually with multiple abnormalities, and an amniotic sac. The characteristic signs and symptoms: intermittent or continuous bright red or brownish vaginal bleeding by 12 weeks of gestation, absence of fetal heart sound. The diagnostic test results: extremely high levels of human chorionic gonadotropin (HCG) for early pregnancy. Ultrasound doesn't reveal a fetal skeleton. The nursing diagnosis: deficient fluid volume, complicated breathing, acute pain. And the treatments include therapeutic abortion, suction and curettage, if a spontaneous abortion doesn't occur, to prevent choriocarcinoma, regular pelvic examinations and chest X-ray, weekly monitoring of HCG level until they remain normal for 3 consecutive weeks, periodic follow-up for 1 to 2 years due to an increased risk of neoplasm. The drug therapy include prophylactic use of methotrexate Trixal, the preferred drug for choriocarcinoma. The interventions and rationales: monitor and record vital signs, intake and output to detect any change that may indicate complications, provide emotional support to the grieving couple, demonstrating concern and understanding for the client and their family, monitor vaginal bleeding to assess for the risk of hemorrhage, send the contents of uterine evacuation to the laboratory for analysis to check for the presence of hydatid vesicles, advise the client to avoid pregnancy until HCG levels return to normal, which may take up to 2 years, to prevent future complications. The teaching topics: explanation of the disorder and the treatment plan, coping with an uncertain obstetrics and medical future, information on birth control methods. The seventh disorder is hyperemesis gravidarum. Hyperemesis gravidarum refers to persistent, uncontrollable vomiting that begins in the early weeks of pregnancy and can continue throughout the entire pregnancy. Unlike morning sickness, hyperemesis can lead to serious complications such as severe weight loss, dehydration, and electrolyte imbalance. The characteristic signs and symptoms: persistent severe nausea and vomiting, dehydration, decreased urine output, oliguria. And the diagnostic test results: arterial blood gas analysis shows metabolic alkalosis, elevated hemoglobin levels and hematocrit, low serum potassium levels indicating hypokalemia. The nursing diagnosis: imbalanced nutrition less than body requirement, deficient fluid volume, acute pain. and the treatments include total parenteral nutrition (TPN), restoration of fluid and electrolyte balance. The drug therapy administration of antiemetic as needed to alleviate vomiting. The interventions and rationales: monitor vital signs, fluid intake and output to assess for signs of fluid volume deficit, collect blood samples and urine specimens for laboratory tests including hemoglobin levels, hematocrit rate, urine analysis and electrolyte levels, monitor the client's fundal height and weight to identify any potential complication, provide small frequent meals to ensure adequate nutrition, administer intravenous fluid replacement and TPN to address fluid deficiency and maintain a proper pH balance, offer emotional support to help the client cope with her condition. The teaching topics: explanation of the disorders and the treatment plan, identifying triggers of nausea and vomiting, using salt on foods to replace lost sodium due to vomiting. The eighth disorder is the hypertensive disorders of pregnancy. Hypertensive disorders of pregnancy encompass gestational hypertension, preeclampsia, chronic hypertension, and superimposed hypertension. These conditions put the client at risk of complications such as cerebral hemorrhage, circulatory collapse, heart failure, hepatic rupture, and renal failure. If delivery occurs before term, the fetal prognosis is poor due to hypoxia, acidosis, and immaturity. Eclampsia carries a maternal mortality rate of 10% to 15%, often resulting from intracranial hemorrhage and heart failure. The characteristic signs and symptoms: for gestational hypertension, development of hypertension without associated proteinuria after 20 weeks of gestation, returning to baseline within 12 weeks postpartum. For preeclampsia, hypertension along with proteinuria. Three categories of preeclampsia: mild preeclampsia, blood pressure 140 over 90 mm Hg, 300 mg of proteinuria in 24 hours. Severe preeclampsia, blood pressure 160 over 110 mm Hg, 5 g of proteinuria in 24 hours, decreased urine output, vision disturbance, right upper quadrant tenderness, and fetal growth restriction. Eclampsia, new onset grand mal seizure in a client with preeclampsia. For chronic hypertension, pre-existing medical diagnosed hypertension or gestational hypertension persisting beyond 12 weeks postpartum, superimposed preeclampsia, chronic hypertension with new onset proteinuria or other signs of preeclampsia. The diagnostic test results: increased blood urea nitrogen, creatinine, uric acid level, and abnormal liver function status. The nursing diagnosis: activity intolerance, excess fluid volume, risk for injury, ineffective breathing pattern, decreased cardiac output. The treatments include bed rest in a left lateral position, delivery mild preeclampsia when the fetus is mature and safe induction is possible, severe preeclampsia regardless of gestational age, high protein diet with moderate sodium intake, fluid and electrolyte replacement balanced with output. The drugs therapy include severe preeclampsia, antihypertensive such as hydralazine or labetalol, corticosteroid betamethasone to accelerate fetal lung mature, magnesium sulfate to reduce acetylcholine production by motor nerves and prevent seizure, diuretics, furosemide Lasix if pulmonary edema develops. The interventions and rationale: for all clients, assess for edema and proteinuria as potential indicators for impending eclampsia, monitor neurological status for early signs of deterioration suggestive of impending eclampsia, track daily weight to identify sodium and water retention, maintain a high protein diet with moderate sodium restriction as a measure against gestational hypertension, implement seizure precaution to ensure safety, encourage bed rest in a left lateral recumbent position to enhance uterine and renal perfusion, monitor blood pressure to evaluate treatment effectiveness, continuously monitor fetal heart rate during labor to assess fetal well-being. For a client with severe preeclampsia, Monitor maternal blood pressure every 1 to 4 hours or more frequently if unstable to detect abnormalities. Prepare for amniocentesis if necessary to assess fetal maturation. Administer IV fluid as prescribed with restriction based on urine output and total fluid intake per hour. Obtain blood samples for complete blood count, platelet count, and liver function studies, as well as serum levels of blood urea, nitrogen, creatinine, and fibrin degradation products to detect signs of complications. Be prepared to obtain a blood sample for typing and cross-matching due to the risk of placenta previa. Collect urine specimen to determine urine protein level and specific gravity, and perform a 24-hour urine collection for protein and creatinine as ordered to evaluate renal function. Monitor urine output to assess fluid status. Keep calcium gluconate, antidote to magnesium sulfate, readily available to administer at the first sign of magnesium sulfate toxicity, elevated serum level, decreased deep tendon reflex, muscle facility, CNS, depression, decreased respiratory rate and renal function. Promote relaxation to alleviate fatigue. Encourage the client to express their feeling to alleviate anxiety. Provide a calm environment to help prevent complications. The teaching topics include explanation of the disorder and treatment plan, importance of bed rest and adequate nutrition, recognizing signs and symptoms of severe preeclampsia and eclampsia. The ninth disorder is the multifetal pregnancy. Multifetal pregnancy, also known as multiple gestation, occurs when two or more embryos or fetuses develop simultaneously. This pregnancy can take different forms. Monozygotic identical twins usually share one chorion, one placenta, two amnions, and two umbilical cords. They are typically of the same sex. Dizygotic, non-identical twins have two chorions, two placentas, two amnions, and two umbilical cords. They can be of the same or different sex. Multifetal pregnancies with three or more fetuses can result from both single ovum and multiple ovum conceptions, or a combination of both. The characteristic signs and symptoms: presence of multiple sets of fetal heart sound, uterine size larger than expected of the gestational age. The diagnostic test results: elevated level of alpha-fetoprotein, positive finding of multifetal pregnancy on ultrasonography. The nursing diagnoses include anxiety, deficient knowledge, pregnancy, risk of injury, and fear. The treatments include activity as tolerated with increased rest of the period, bed rest if early dilation occurs, or at 24 to 28 weeks gestation to improve uterine blood flow and potentially increase birth weight of the fetus. Biweekly non-stress test (NST) starting at 28 weeks gestation to monitor fetal growth, increase intake of calories, iron, folates, and vitamins. Prenatal visit every 2 weeks, increasing to weekly between 24 and 28 weeks gestations, with cervical examinations performed at each visit to check for premature dilation, monthly ultrasound examinations to monitor fetal growth. The interventions and rationales: monitor fetal heart sound to assess fetal well-being, monitor maternal vital signs and weight to evaluate maternal well-being, monitor cardiovascular and pulmonary status for signs of gestational hypertension, ensure adequate nutrition and increase intake of folate, calories, vitamins, and iron to promote appropriate weight gain, encourage frequent rest period, particularly in the third trimester, or recommends bed rest if necessary to prevent fatigue, provide emotional support and encouragement to alleviate anxiety, advise the client to follow the scheduled ultrasound examination and NST appointments to monitor fetal well-being. The teaching topics: pregnancy needs and expected course, notifying the physician immediately if signs of premature labor occur, abstaining from sexual intercourse during the third trimester.